Thanks so much, Mr. Chairman, and thanks Professor Ahmed Nasif and Professor 𝗏 Hin-Dawi for the kind invitation. 𝗍 is better than open repair for ruptured AAA. 𝗍 is the gold standard. Open ruptured AAA is a criminal act. The aftermath of 𝗏ICE guidelines, and we have a lot of our colleagues from the UK, and hopefully they don't be annoyed for what I'm going to show them.
Theresa May, when did you realize that you got the wrong answer to the biggest question of our times in politics?
Well, I'm tempted to ask you, Jeremy, what you think. Do you mean that you're talking about Brexit?
Well, of course.
Right.
Unfortunately, the change to the new occupier of number 10.
We have never had it so good. We are selling tea to China.
Into account our high standards to make sure our farmers are undermined. Pentonville last week, they've now got patrol dogs who are barking, which helps deter drones.
We're expecting the first refugees to arrive next week in the United Kingdom. I don't know exactly how they will get to the United Kingdom, but I know that we expect.
So if you follow the 𝗏ICE guideline, it's exactly the same problem that you face in here. 𝗏ICE recommend an open first strategy for ruptured AAA in men based on UK in-house economic modeling. European Society for Vascular Surgery recommended 𝗍 first strategy. This is two European organizations against each other. And this is the 𝗍 first blood. This is the 𝗏ICE and this is the ACVS. And you can see that the ACVS, 𝗍 should be considered in patients with reasonable life expectancy. Open repair should be considered in patients with long life expectancy. AAA repair is not recommended in patients with limited life expectancy. On the other hand, the 𝗏ICE guideline is completely opposite. Then they tried to get an eye-to-eye to the problem and for the open and the endovascular repair. And again, both of them are on a completely different planet. This controversial recommendation is attributed to dwindling loss of the 𝗏's influential power post-Brexit. 𝗏ICE concede that 𝗍 mortality are better than open repair in perioperative period and remain equivalent up to 8 years. Although 𝗏ICE accept that this is old data, they declare that they found no evidence that newer devices perform better than their earlier counterparts and did not consider it to be a reason to reject the evidence-based. Then Janet tried to be 007 and she failed miserably. We couldn't even get it right in her article. We replied that to her about the enigma of the 𝗏ICE guideline, and this was supported with the ACVS that have published a big report about the problem. So if you look at the history and endovascular inexperience versus 𝗍 is feasible and safe in hostile neck anatomy, and this is over time, until this year where they found that failure to rescue in ruptured AAA patient deemed anatomically ineligible for 𝗍 must be referred to high volume centers. We have solution that you don't have. Resources must develop protocols targeting specific complication to mitigate risk of prevent post-operative death. Again, let's look what's happening. Durable, sustainable mid-term outcome were found for 𝗍 and 𝗍 who survive post-operative period. Patients treated outside the indication for use are at the greater risk for late complication. Everybody knows that. However, meta-analysis of more than 250,000 patients, the difference in perioperative mortality in favor of 𝗍 has become more pronounced, significant association between perioperative mortality and caseload. And then we'll come back to the latest one. 𝗍 only strategy has allowed 𝗍 to be used in nearly all rupture with similar mortality comparing with 𝗍 selected strategy. Due to the avoidance of operative mortality selection, the 𝗍 only strategy was associated with a more simplified algorithm, better operation, better recovery. And we start finding all of that in all of our patients as they come. However, what we have seen that local improved perioperative mortality in hemodynamic stable patients and should be recommended for patients undergoing 𝗍. Do it under local, they do very well, no problem at all. 𝗍 have a better outcome. However, the argument was perioperative mortality halved by use of 𝗍 from 40 to 20%. We must keep doing open for the sake of training young vascular surgeons. However, another publication just came this year. Double and sustainable mid-term outcome were found for 𝗍. Patients treated outside the indication for use are at the greater risk for late complication as for elective done under indication for use 𝗍. No difference. Again, we're going to go in about the aggressive volume resuscitation, do hemostatic hypovolemic resuscitation, do not transfuse the patient. In both stable and unstable, 𝗍 is associated with diminished 30-day mortality and morbidity. And again, 𝗔𝗏 showed sustained mortality benefit during follow-up compared with open repair. Now, accept no fear, no limits to excuse it, just do it. Do not say that's difficult. All cases are difficult. But if you work in a big center, you'll be able to overcome all difficulties with a lot of tricks that I'm going to show to you. Patient comes with free rupture. You have that day in, day out. They'll phone you. You have to be within 15 minutes away from the hospital. You come in, you give local, and you have to go in and save the patient's life. And the only way to do that is endovascular clamping. And the only way to do that, you need to get a long sheath, 65 𝗓 and put a balloon and inflate it in the suprarenal and use the contralateral to do the angiogram. You don't need to put a pigtail except at the end where you're going to have the outcome. And it's reproducible. Another rupture came in, the same exactly. You get in, you get the patient back to theater, you give him local, and then you go in, and after giving the local, you're going to put your endovascular clamping, and then after the endovascular clamping, you're going to do the angiogram through the contralateral side, and then you put your endovascular graft. Now, dress technique is when you have severe angulation, you put a giant palmas or 36XL stent to hook the stent on it. And then the dress technique is, we published it almost about 12 years ago, and it's the only way to save in this problem with angulating necks. Moreover, if you have wide, short, wide neck, you could use C-tag inside an AFX, and it will seal perfectly well, up to 45 millimeter in diameter. Without a problem, do not put chimneys. They will kill the patient. Now, this patient comes in with a bilateral common iliac, just landed an external iliac. There is no shame about it, and do not be afraid about it. Juxtarenal aortic dissection, you have to have an inflow and outflow, otherwise the patient will not do well at all. So don't get afraid about doing extensive intervention. It's the only way to save. This patient will be dead anyhow if you do nothing. This is a patient came in with a complex 𝗔𝗏. You don't need to do 𝗙𝗏 or 𝗔𝗏. You have a lot of things in your hand. Try to simplify your solution. Any complexity will end in problems. This is a patient came in with 𝗓𝗏𝗃𝗃 problem, so we put an 𝗙𝗏 in the inferior vena cava and 𝗙𝗏 in the AAA, and you could see the dual 𝗙𝗏. Another patient came in with a rupture inferior vena cava and common iliac, so he needed 𝗙𝗏 and a 𝗙𝗏 for 𝗓𝗏𝗃𝗏 fistula, and this is a follow-up after 10 years. The 10th commandment, do not kill. It's very important to understand that. And it's very important to understand that introduction of 𝗙𝗏 resulted in reduction in AAA mortality from 53 to 21%. Those shall not deny significant evidence of increased survival with 𝗙𝗏 are denying life for the patients. Low mortality rate of 𝗙𝗏 versus open repair is due to introduction of 𝗙𝗏 program and technical imaging and advancement in endograft. Those shall not deny lower mortality rate with 𝗙𝗏, again, will kill a lot of patients. Lowest mortality for rupture was seen in large teaching hospital with 𝗙𝗏 first surgery. 𝗙𝗏 in the elderly is associated with better pre-op survival and 30-day outcome compared with traditional open repair. Do not convey the neighbor expertise, but create a place for them to flourish. This meta-analysis of 60,000 patients reveals substantial survival benefit of 𝗙𝗏 compared with open repair for AAA, early mortality benefit after 𝗙𝗏, which persists over the midterm. Honor the center with low mortality. 𝗙𝗏 offers faster discharge with better quality of life. At 3 years, mortality is reduced with 𝗙𝗏 and is cost effective. Do not worship open repair in rupture AAA when 𝗙𝗏 has lower mortality. Multi-center cohort study spanning 49 institutions shows superiority of 𝗙𝗏 over open repair in terms of 30-day mortality. Again, when many speak, please listen to them. Do not be stubborn about the situation. Decrease in AAA-related deaths of 38% is not a continuing effect of medical advancement, but a result of 𝗙𝗏 and endovascular specialization. Statin is useless, by the way, in that situation. Facts do not lie, shall you see. Improved mortality outcome and decrease in rupture AAA is due to AAA screening, 𝗙𝗏 and vascular surgeon performing 𝗙𝗏 better than any other specialty with superb cost effectiveness. The price of wisdom is above the rubles. 𝗙𝗏 should be used more widely. Shall honor endo and keep all weak for shall do 𝗙𝗏 for rupture AAA. 𝗙𝗏 should be the gold standard. I have a good fight, and I have to show you the conclusion. Giant AAA must be mastered by open surgical repair in deliberate high volume surgeon and center. AAA must be repaired in a smaller diameter, especially in women, with precision designed graft to ensemble patient from oversizing with minimal number of modular or limb components. Mr. Chairman, ladies and gentlemen, Investigation of 𝗙𝗏𝗏 must be only executed during a course of clinical trial with a study safety committee. Avoid complex aneurysm repair in octogenarian by overzealous interventionists, as majority represent an end-of-life scenario. Thank you so much for the opportunity to present today.